All right. Welcome, everybody. This is the Department of Internal Medicine Grand Rounds. Today is Thursday, January 23rd, 2025. We do invite speakers from other departments to share some insight and some specialty knowledge about 4 to 5 times throughout the year. So today's speaker comes from the Department of Psychiatry. Dr. Tushar Thakre is an associate professor of psychiatry in the School of Medicine here at VCU. He serves as the division chief and medical director of Inpatient and Acute Psych and Neuromodulation here at VCU Health. He obtained his medical degree from the Government Medical College in Nagpur, India. This was followed by a PhD in integrative physiology at the University of North Texas Health Center in Fort Worth, Texas. He then completed his residency in psychiatry at the University of Missouri, Kansas City, and fellowship in sleep medicine at the Cleveland Clinic. He is dual board certified in psychiatry and sleep medicine. Dr. Thakre is an elective fellow of the American Academy of Sleep Medicine and was inducted as a distinguished fellow by the American Psychiatric Association. His academic interests include the intersection of psychiatry and sleep disorders, neuromodulation, and the use of artificial intelligence in healthcare. Today, he's going to talk to us about neuromodulation therapies and take a deep dive into ECT and TMS therapy and explore some of the newer therapies that are coming on the market and soon here to VCU. Please help me in welcoming Dr. Thakre for our presentation.
Thank you, Dr. Bergman. It is an honor to present to you guys and to talk about some things I'm really interested in. And hopefully at the end of this talk, there may be some interest in potential collaborations between our two departments. So I'm going to talk, like Dr. Bergman said, mostly about ECT and TMS, but also I'm going to mention esketamine. That's a therapy that we'll be offering in the coming months. I do not have any conflicts of interest related to this topic. So what I want to talk about today is introduce the term neuromodulation and the different neuromodulation modalities that are currently in clinical and academic use. And I'm going to talk about the therapies that we offer here, namely ECT and TMS. ECT stands for electroconvulsive therapy and TMS is transcranial magnetic stimulation. And then I'll talk about some of the newer exciting stuff coming to VCU Health. So what is neuromodulation? So the International Neuromodulation Society defines neuromodulation as the alteration of nerve activity through the targeted delivery of a stimulus. And this can be any kind of stimulus. We can do an electrical stimulation, we can do magnetic stimulation, we can do light, sound, even chemical stimulation. So the stimulus can vary and it can be applied to specific neurological sites in the body. So not just the brain, but you can also target peripheral nerves with this stimulation. So as compared to direct action of a neurotransmitter on a receptor, neuromodulation works by influencing neuronal function in an indirect fashion. And it's not a first-line treatment. It is reserved for cases where standard treatments such as medications and psychotherapy, if you're talking about psychiatric illnesses, they have not been successful and you want to try something else, that's when you try the neuromodulation techniques. Also, this is the effects of neuromodulation therapies is not immediate. It's not like an on-off switch. It takes time for the brain to either have neuronal processes enhanced through long-term potentiation or diminished through long-term depreciation because it takes time to reset the circuitry. So this can take a few weeks in the case of ECT, or it can take a couple of years in something like a vagal nerve stimulator. So it takes time, basically, for these things to work. So I have listed many of the neuromodulation therapies that are currently in clinical use or under investigation. And this is not a complete list. I'm sure there's many more out there that are not captured on this slide. But I'll focus mostly on the left side here, where we'll talk about electroconvulsive therapy or ECT, which is used for a variety of psychiatric illnesses such as major depressive disorder, treatment-resistant schizophrenia, mania, or catatonia. Then we have the newer technology, the transcranial magnetic stimulation, which is also indicated for major depressive disorder, anxiety comorbid with depression, obsessive compulsive disorder, and most recently nicotine addiction as well. And then the third thing I'm going to talk about is nasal esketamine therapy, which is indicated for major depressive disorder and acute suicidality. You might have also heard of intravenous ketamine, It is used off-label for major depressive disorder. We don't offer that here, and I'm not going to talk about it. In the neurosurgical world, we have vagus nerve stimulation, deep brain stimulation, and focus ultrasound. And some of those have effect on the mood as well. So vagus nerve stimulation is primarily used for treatment of epilepsy. But we'll notice that people who have this vagus nerve stimulator, they also have depression. After a couple of years of having the stimulator on, they notice an improvement in their mood as well. Similar thing with deep brain stimulation, it's used for movement disorders, but it's also shown to be effective in obsessive compulsive disorder. On the right side, where we have therapies under investigation, like I mentioned, the stimulation for neuromodulation can be a variety of things. It can be electrical stimulation, it can be direct currents, transcranial direct current stimulation or alternating current stimulation. You can use magnetic currents to induce seizures. And there are other kinds like ultrasound or optical or optogenetic stimulation. So there's a multiple variety of things that are under investigation. So let's talk about electroconvulsive therapy. So ECT is the application of an electrical stimulation to the frontal or temporal area of the head to generate electrical currents large enough to induce depolarization of a large number of brain neurons, which results in a seizure. So the seizure is the primary mechanism by which ECT works. It is very effective, among the most effective treatments in psychiatry for severe mental illness. However, it is grossly underutilized because of stigma, because of the negative portrayal in media, and because of this unholy trinity, where this electricity is involved, there's convulsions involved, and memory loss is one of the side effects. So people are very wary about it, and I think there's because of lack of education about it. I think there's underutilization of this very useful and safe therapy. So electric and magnetic fields, the use of electric and magnetic fields in medicine is not a new concept. It has been around for a long, long time. As far back as 46 AD, this gentleman was using aquatic animals capable of electrical discharge and applying it to the body for treatment of various conditions like headache, arthritis, and gout. Some people even tried to induce electric currents by using glass globes, revolving glass globes, and drawing sparks through affected body parts. Galvani in 1780 was the first to report that electrical stimulation causes twitching of frog leg muscles. Matteucci demonstrated that injured tissue also generates electric currents. So a body is capable of generating electric currents, electricity, as well as responding to it. In 1934, a significant event happened where von Meduna, a Hungarian neurologist and neuropathologist, he noticed that in his patients with schizophrenia, if they had a seizure, they seemed to get better. Their psychosis seemed to improve. And he was also a histopathologist, so he did brain autopsies on patients who had schizophrenia and epilepsy. And he compared the histological changes, and he noticed that the changes seen with epilepsy are not present in the brains of patients with schizophrenia. So he came up with the concept that maybe seizures are an antidote to schizophrenia and psychosis. And then he experimented with methods to induce seizures. And in the beginning, it was mostly chemical-induced seizures. So this included IV camphor, Pentylene tetrazole, inhaled fluorothil, or even use of insulin-induced hypoglycemic coma. And they found that it was effective in many cases. The problem was the seizure induction was unreliable with these drugs. It took a long time to induce the seizure, and the patient was just waiting, and they would feel discomfort, fear, and anxiety. So it was difficult to control those seizures. So in more modern times, in 1937, Serletti and Binney were the first to report animal experiments on dogs where they were able to induce seizures by using electric currents. And then they devised and designed and built the first ECT device in 1937 or 1938, and they utilized it on the first human subject with schizophrenia. So ECT has been around for a long, long time, almost 90 years now. It came to the US in 1940 and then to the rest of the world soon after. They found that the electricity-induced seizures were less violent and shorter in duration, and so ECT became the preferred mechanism to induce seizures as compared to drugs. But in the early years, there were still some drawbacks because the patients were conscious. We were not using anesthesia at that time, right? and there was no paralytic agents used. So they were actually having motor seizures, and they were prone to develop bone fractures or even muscle tears. So it was in the 1950s when the modified ECT technique or modern ECT technique came into being, where we started using anesthetic agents as well as paralytic agents. And that made the world of difference, where it's now a very safe procedure. So these are the indications for ECT. Serious mental illnesses like unipolar major depressive disorder, bipolar disorder, treatment-resistant schizophrenia, catatonia, and all age groups, you can use it, especially effective in the elderly patient, but also in adolescents, you can do ECT. And if there's some urgent situations, like if the patient is severely depressed or suicidal and they're pregnant, or they're not eating, if they have persistent suicidality, and neuroleptic malignant syndrome, which is a side effect from psychotropic medications, all of those emergencies, you can use ECT as a treatment. Now, how does ECT work? The short answer is we don't know for sure. But these are the various things that we know happen with ECT. So there's an alteration of brain blood flow and metabolism. There's effects on the immune system. There's effect on neuroendocrine system. There's effect on the levels of various neurotransmitters. There's neurotropic effects, genetic effects, and also the anticonvulsant effects of ECT. So although ECT induces seizures, it also raises your seizure threshold. So the more ECT treatments you get, it becomes harder and harder to induce a seizure. So it has anticonvulsant effects itself. And it is thought that that is one of the therapeutic mechanisms of ECT. But again, we don't know for sure. We know it works, we don't know how it works. So these are the steps involved when we do an evaluation and workup for ECT. Obviously, the patient has to have a disorder that responds to ECT. Although it has a wide range of conditions that it treats, not everyone is a good candidate. So we also establish a baseline for psychiatric and cognitive functioning, because with ECT treatments, your cognitive functioning can be impaired. So we need to establish a baseline and then compare it after the treatments to see if it has declined. There are no absolute contraindications to ECT. So you can, if you think the patient needs it and the benefits outweigh the risks, then yeah, there's no contraindication to ECT. But there are certain relative contraindications like cardiopulmonary disease or cerebrovascular disease, bleeding abnormalities, presence of intracranial masses, ASA class 4 and 5. So in those cases, we might, in more complicated cases or patients with severe medical comorbidities, we might consult cardiology or neurosurgery as well as anesthesiology as needed. It is also something we need informed consent from, either from the patient, or if the patient is incapable of providing consent, then we go to the legal next of kin, or we get judicial consent for that. So the workup, you just do basic labs, BMP, CBC, you might get an EKG, head imaging if needed. We don't perform chest X-rays and spine X-rays. So we don't need too much of a workup prior to initiating ECT treatments. So this is our ECT suite. It's on North Hospital, 3rd floor. That's where the inpatient psychiatry units are as well. It's a team effort. So we have the attending anesthesiologist and CRNA usually is present. And then there's an attending psychiatrist and psychiatry resident, as well as ECT nurses. So this is where we do the treatment. And soon after that, they go into the room on the left for the monitoring. And then they go to the recovery area on the right. And they stay there for about an hour, where we monitor them for vitals and any other complications from ECT. And then they either go back home or they go back to the unit. So we do both inpatient and outpatients in the same location. So these are some of the parameters. This is an example of the machine that we use here. So there's the charge, right? So 100% of charge equals 504 millicoulombs. That's the maximum that we can deliver. Usually for young patients, we start at around 10% of the charge. And then, as I said before, that with repeated ECT treatments, it gets harder and harder to induce a seizure. So for subsequent treatments, we might need to go up on the charge. You can go all the way up to 100%. The current is 0.9 amperes, frequency is 10 to 70 hertz. The waveforms, there's different waveforms. The one we use is bipolar, that has less chances of causing cognitive side effects. Another important factor is the pulse width. So the standard that we use is 0.5 milliseconds. It is considered brief pulse width. But in cases where there's already baseline cognitive dysfunction and we are worried about cognitive side effects, we might even go shorter, like 0.25, which is ultra brief pulse width. So there's a different things we can play with: the charge, the pulse width, as well as the waveform, and also the ECT electrode placement. So there's different areas that we can stimulate with ECT. So, and there's pros and cons to each of those. And by the way, this is not a real patient. One of our residents volunteered to do this. So the first one is the right unilateral. So we put one electrode on the vertex and the other one on the right temporal area. So this one is not as strong as the bifrontal or bitemporal treatments, but it is less, it's less risk for cognitive side effects. So we might start someone off with this, and then as the treatments progress, we might switch to the other placements. Then the second one is the bifrontal, which is kind of in between. It has medium effectiveness and risk for cognitive side effects. Similar thing is the left anterior, right temporal, where you have one electrode on the left frontal area and the other one on the opposite side in the temporal area. And then we have the bitemporal placement, which is the strongest stimulation. It is most effective, but also has the highest risk of cognitive side effects. And you would use it in more serious illnesses like manic episodes or catatonia or schizophrenia. So these are the steps, ECT procedure. This is Dr. Venkatachalam, our ECT director. And again, this is a volunteer. This is all a simulation. This is not a real patient. So we confirm that the patient is NPO because they're going to go under anesthesia. We also make sure there are medications, certain medications that could interfere with ECT have been held. These include benzodiazepines or anticonvulsant medications. The patient has an IV access, and then we monitor several things. We attach EEG electrodes, we monitor their EKG, we also monitor electromyograph, and then also the ECT electrodes with the placement that I mentioned in the previous slide. We do a timeout before the procedure. We administer any pre-procedural medications, and then we administer our anesthetic agent. After that, we inflate a blood pressure cuff around one of the feet and around the ankle, one of the ankle, to isolate the foot. So that foot does not get the paralytic agent. And that is just to show us whether to confirm that the person is actually having a motor seizure, because the rest of the body would be paralyzed and only that foot would move when we give the stimulation. And because of the effect of then we administer the paralytic agent, and that will cause paralysis of most of the skeletal muscles. So then they will need ventilation with a bag and mask. And we'll also need to use a bite block, because although the muscles are paralyzed, just because of the stimulation close to the masseter muscles, the masseters are directly stimulated and they bite. So we have to make sure to protect the teeth as well as the tongue from injuries. We use a bite block. And then after all this, we deliver the electrical stimulation. That's the button we push. This is just an example of after the stimulation, you'll see the jaw clench and you'll see the foot move. So in the EEG, we'll see the classical spike and wave EEG pattern of the seizure, and it will go on for a while. And usually we also have the EMG running right below that, so we'll capture the movement of the foot on that channel as well. You'll see after a while the seizure activity will slow, and then it will get resolved towards the end. We do want the seizure to last at least 25 to 30 seconds. That's considered an adequate seizure duration. But we also don't want it to go on for too long, otherwise it will cause other problems like cerebral edema and stuff. So if it goes more than 100 seconds, then we may need to stop it with either propofol or midazolam. So these are the various anesthetic medications used in ECT. And the one that we use primarily here is methotrexate. We like it because it's a short acting agent. Its duration of action is 30 to 60 seconds. Onset takes only 30 to 60 seconds, and it lasts only 5 to 10 minutes. We don't need a lot of time to deliver the stimulation. The stimulation lasts about 8 seconds, and then the seizure, like I said, we don't want it to go on for too long, so less than 2 minutes for the seizure. So we don't want the person to be asleep for a long time. So that's why we prefer methotrexate. It can cause hypertension, respiratory depression, and sedation, and it can also cause like jerking movements in the limbs when you first give it. It's a barbiturate, it acts on the GABA receptors. Or other agent that we sometimes use is etomidate. If for some reason we don't have methoxytol, like we had a shortage some years ago, or there are other reasons why we don't want to use methoxytol, then we can use etomidate. It is also similar in duration, onset of action and duration. It also causes, there's rapid recovery from the anesthesia. It can cause myoclonus, pain on injection, and adrenal suppression with prolonged use. Some places also use propofol, which is also another good agent. It can be associated with hypertension, respiratory depression, pain at injection site, and requires careful monitoring of BP and respiration. Also, it can interfere with the seizure itself. So methoxytol is the preferred agent for a variety of reasons, including not interfering that much with the seizure reduction. Then thiopentol is another one. It's also a barbiturate, and it's also a good alternative if none of the other agents are available. Another agent is ketamine. Ketamine by itself is used for depression, as you know, and I'll talk about esketamine as well. But the addition of ketamine and ECT has not been shown to, I mean, it does not seem to confer any additional benefits on the disorder, on the depression or other condition that you're treating. So it can be used, but we prefer methoxytol. It also comes with some side effects like hallucinations and vivid dreams, and as well as the increase in blood pressure. Midazolam is not used by itself. It can be used combination with other agents, and it can, like I said, it can be used to stop a seizure or also for any agitation post-treatment. Speaking of paralytic medications, so there's two categories. There's a depolarizing neuromuscular blockers and non-depolarizing neuromuscular blockers. So succinylcholine is the one we use. Most often it mimics acetylcholine at the neuromuscular junction. It's a short-acting agent, takes 30 to 60 seconds to start working, and then it lasts only 4 to 6 minutes. Again, we want something that's short-acting. It allows rapid recovery after treatment. There are certain cases where there's a risk for hyperkalemia, especially in patients with burns, trauma, or neuromuscular disorders. And in cases where we cannot use succinylcholine, we would use a non-depolarizing neuromuscular blocker like rocuronium. Rocuronium has a longer duration of action. It can last about 30 to 60 minutes. It does not have a risk for hyperkalemia or malignant hyperthermia, but it takes longer time to recover, requires careful dose adjustments, and if the paralysis is prolonged, you may need to reverse it with something like sugammadex. Also, tachycardia and hypertension can occur. So our preferred agent is succinylcholine. If there's some reason we cannot use succinylcholine, then we would go to rocuronium. And rocuronium's cousins, vicuronium, atracurium, and cisatracurium, can also be used, but we really have not used it. Mostly just succinylcholine or rocuronium. Then those are the main agents, an anesthetic agent and a paralytic agent. We need to use one of each during each treatment. But there are other medications we can use for other things that happen. So patient may complain of headaches or muscle pains, and we use ketorolac, we use ondansetron for nausea. We may use a beta blocker for high blood pressure, tachycardia stuff. They might have increased secretions under anesthesia, so we may use glycopyrrolate. Caffeine can enhance the seizure. So if we reach 100% energy and we're still not getting a good quality seizure, then we might give caffeine before the treatment, and that enhances the seizure as well. And I mentioned sugammadex, it's for reversal of the non-depolarizing paralytic agents, rocuronium. So side effects. So the seizure itself raises the adrenergic drive, and it can elevate your heart rate, blood pressure, intracranial pressure. And if you don't use dental guard, it can lead to dental injuries, tongue injuries, and even fractures if the patient is not sufficiently paralyzed. So we need to make sure they are adequately anesthetized as well as paralyzed. Post-treatment, there can be agitation, headaches. Now, memory deficits is the big one that most people are worried about, and it can be both retrograde or anterograde amnesia. But usually after you stop doing the treatments, within 2 weeks, memory returns. But it may happen that they may not remember events that happened during the course of VCT treatments. Other things like aspiration pneumonia, confusion, delirium, especially after the bilateral ECT, there's a risk for delirium and muscle soreness, back pain, nausea, vomiting. These are all other side effects. So how do we go about the course of ECT treatment? So we have something called the index treatments, and then we do maintenance treatments as well. So the index treatments last about 8 to 12 treatments. Right now we're doing them 3 days a week, Monday, Wednesdays, and Fridays. And we do them until the symptoms respond and then plateau that we don't see improvement after for 3 subsequent treatments. Many people then go into the maintenance therapy, especially for mood disorders or schizophrenia. And this can start off on a weekly basis, and then we gradually spread them out to once every 2 weeks, once every 3 weeks, 4 weeks, 2 months, and up to 3 months. And we have people who've been coming here for years, getting their tune of, I guess, ECT every few months, and then they do pretty well in the intervening period. Okay, so switching gears here. So we talked about an electrical neuromodulation technique. Now let's talk about magnetic neuromodulation. And we have a couple of machines to do this. The technique is called transcranial magnetic stimulation. So TMS involves non-invasive electrical stimulation of surface areas of the brain. And here, instead of electricity, we're using magnetic fields to depolarize neurons in a focal area. The advantage of TMS is that you do not need any anesthesia or sedation. So it's an outpatient procedure. Patients drive themselves here, they get the treatment, and then they carry on with their life. So it doesn't take long either, less than an hour for everything. So it's safe as well as effective. It's not as strong in terms of effectiveness as ECT, but it's about 60 to 80% of the treatments. I mean, they result in substantial benefit. So just like ECT, I mean, use of magnets has been around for a long time. So Anton Mesmer came up with the concept of animal magnetism, like all human beings have magnetism, and that magnetic fields in the body respond to heavenly bodies as well as the environment. Then over the centuries, there has been this concept that magnetic stimulation of the body could serve as a nutrient to the body. Michael Faraday was the first to demonstrate that electrical fields and magnetic fields are connected, that passing an electric current through a wire coil can generate a magnetic field. D. Arson Wall, back in 1896, actually did something, a crude version of TMS, where he put someone in their head inside a strong magnetic coil and induced various symptoms such as vertigo, syncope, and phosphorescence. It was not until 1985 when the first modern TMS device was built. And in 1995, the first studies came out where high frequency TMS was applied to the left prefrontal cortex. So the indications for TMS are somewhat different than for ECT. So depression is common. So major depressive disorder, you can do this both for ECT and TMS. It's also received approval for migraines with aura in 2013, for obsessive compulsive disorder in 2018, nicotine addiction in 2020, anxiety comorbid with depression in 2021, and most recently post-traumatic and post-surgical pain as well, 2020. So every few years, there's a new indication coming out. And I mean, outside the US, in Europe, there's about 17 or 18 conditions that are being treated with TMS. And in 2024, it also got approval for adolescents 15 and older for treatment of major depressive disorder. So there's a lot of different conditions as well as age groups that can be targeted with this treatment. Just like with ECT, we don't know how TMS works. It alters brain activity, it can have effect on brain connectivity, it alters the levels of monoamine neurotransmitters, it affects the neural oscillations, it has some genetic effects, affects the immune and inflammatory system, as well as neuroplasticity and long-term potential. So the brain areas that we want to target with TMS are situated deep inside the brain, okay? So such as the amygdala and the anterior cingulate gyrus. And the magnetic fields cannot reach those areas directly. So we do an indirect stimulation of those areas by targeting the left dorsolateral prefrontal cortex. So that's pretty close to the surface. And the magnetic fields travel not far from the magnet. It's about a couple of centimeters. So we are able to reach the prefrontal cortex, but not the deeper structures. But by stimulating the prefrontal cortex, because of the connections inside, we are able to reach those deeper areas as well. And the left DLPFC is not the only area that is targeted. Some people have tried doing the right DLPFC, the dorsomedial prefrontal cortex, as well as the anterior cingulate cortex. So electric current is passed through a metal coil, which is placed against the scalp, and it generates a pretty strong magnetic field, 1.5 to 3 Tesla. So it's comparable to an MRI device. The difference from an MRI is that the field does not travel very far. It's very close to the magnet, whereas with an MRI, it will occupy the entire room, and we have to take precautions to make sure there's no metal inside the room. But here we don't need to be that careful. I mean, we just need to make sure there's no metal within a foot of the magnet. So that leads to stimulation of the cortical and subcortical neurons, which leads to alteration of blood flow and neurotransmitter release and has distal action on deeper structures. So this is one of our TMS machines, and the magnet is housed inside the helmets there. I mean, the magnetic coil is housed inside the helmets. So we place the magnet, which is inside this bar here, against the scalp, and the stimulation of the dorsolateral prefrontal cortex causes neurotransmitter release in deeper brain neurons, and then that has secondary effects on the remaining portions of the motor circuits. And we can see those after a course of TMS, we can see those areas light up on imaging. So there's different types as well as protocols for doing TMS treatments. Okay. So the two machines that we have and the two basic machines that the technology is either surface cortical TMS or a deep TMS. And then there's different protocols. We have the standard protocol, and then there's other protocols like accelerated TMS, high dose TMS, theta burst, bilateral, and something called the SAINT protocol. So this is our surface TMS machine. This was the first machine to receive FDA approval. And we've had this machine for a long time, since probably 2009 or 2010. The magnet, the coil inside is in the shape of the figure of 8. And it's housed inside this, this bar here. So this is where the magnet is located. Okay. So the patient sits in this dentist chair kind of setup, and then we place the magnet on the side of the head. So the magnetic field generated by this figure of 8 coil is pretty focal. So you have to be pretty accurate with the placement of the magnet. So the patient's lying reclined, and then we put the magnet on the side of the head, and then we do the stimulation there. So surface TMS is a form of repetitive TMS that stimulates the cortex using standard figure of 8 coils. Its other names are surface cortical TMS or superficial TMS. And generally we target the left DLPFC, but like I mentioned before, you can also do the right DLPFC, or you can do sequential or simultaneous stimulation of the left side as well as the right side, doing the left high frequency stimulation of the left side and low frequency stimulation of the right side. And you can also do the dorsomedial prefrontal cortex. And this is the device that has been approved for use in adolescents with major depressive disorder. So this is how the treatment goes. We do, on the first day, we do what's called as brain mapping. So we try to figure out where the prefrontal cortex is located, okay? And we don't have brain imaging, not yet. We'll have that capability coming soon. But to figure out where the DLPFC is located, we first figure out where the motor cortex is located, and we try to isolate the thumb by giving magnetic stimulation, just single pulses to the motor area. And then once we figure out the area, then we see how much energy we have to deliver in order to get an effect, a movement in the thumb about 50% of the time. So that's called your motor threshold. Every person has a different motor threshold. Different things affect your motor threshold. Once we find where the motor area is, then we move the coil 5.5 centimeters forward, and that's our treatment area. The stimulation happens at 120% of the motor threshold, and the pulse sequence is, it stimulates at 10 hertz for 4 seconds, and then there's a 26-second quiet period, and then it repeats this for a while. It takes about 37 and 38 minutes, and we deliver a total of 3,000 pulses in that time. Now let's talk about deep TMS. So like I mentioned, this is the one that uses helmet, and the shape of the coil is in the shape of an H instead of shape of figure of 8. It's called deep TMS because it has a deeper, it penetrates deeper into the brain tissue, but it's maybe another extra centimeter as compared to the other device. But it also stimulates a wider area of the brain. So we don't need to be as precise with placement as compared to the other machine. There's various helmets for different indications. So the gray helmet is for major depressive disorder. The yellow one is for obsessive compulsive disorder, and they have another one for nicotine addiction. So here the patient is sitting upright, and we do the similar thing. We do brain mapping on the first day. We figure out where the motor cortex is, and then we move the helmet forward to stimulate the DLPFC. So these are different coils inside those helmets. Okay, so the H1 coil is the one that's used for major depressive disorder. H7 is for obsessive compulsive disorder, and H4 is for smoking cessation. So this stimulates not only the superficial prefrontal cortex, but also structures, subcortical structures as well. And it also has a deeper and wider distribution than the figure of 8 coils. Although there's no head-to-head comparison, and it's unclear if the stimulation of the deeper areas has clinically or physiologically meaningful effects. Just based on our own clinical practice, we've noticed that patients tend to respond better to this deep TMS treatments as compared to the surface TMS. So steps are similar. You do the brain mapping to determine the motor threshold, and then we move 6 centimeters anterior. The treatment is at 120% of the motor threshold. And then the pulse sequence is a little bit different. You do 18 hertz frequency for 2 seconds, and then we wait 20 seconds and we do it again. We do 55 trains of that, and we deliver a total of 1980 pulses or 19 minutes. So this is a shorter protocol as well. Let's see if this video will work. But what I want you to look at is the right hand, okay? You will see pitching of the hand. Okay? So we're just doing the brain mapping here, or simulating a brain. Again, this is a simulation, not a real patient. Did you see that? I can play it again if you haven't. Let's do it again one more time. Just look at the right hand. Okay. So that's the brain mapping to figure out where the motor cortex is, and then we move forward to the actual treatment. Okay. So this is just a screenshot of the device screen where we have the power. Again, this person needed 48% power. That's because that's where the motor threshold is. The 120% of the motor threshold is 48. 18 hertz frequency, 2-second duration of the stimulation. And so that's equals 36 pulses delivered over 2 seconds. We wait for 20 seconds, and then we do this 55 times for a total of 1980 pulses. So here you see for the 2 seconds, it's delivering this pulses, and then there's a wait period of 20 seconds, and then we do another round. So this is what the machine sounds like. Okay, so that's 2 seconds of stimulation. It gets louder than that because this is a simulation. We did it at a lower energy, but it gets pretty loud. Okay, so that was the standard TMS protocol. We also have some experimental TMS techniques like accelerated TMS. So instead of doing just 1 session a day, we can do multiple sessions per day and end the treatment in less than 4 weeks. Or instead of doing 3,000 pulses, we do a double dose. We do 6,000 pulses per session. And there's something called theta burst TMS, where you do pulses at 50 hertz frequency at 5 per second. And this is intended to mimic the endogenous theta rhythms inside the brain. This appears to exert longer lasting effects upon motor cortex excitability and requires less stimulation time. So instead of the 20 to 40 minutes that we need with the standard treatments, this can be done in 3 to 6 minutes. So it's a much shorter treatment time. And then we can also do bilateral TMS, where you do high frequency stimulation of the left dorsolateral prefrontal cortex and low frequency stimulation of the right side, either simultaneously or sequentially. And it is thought that this bilateral stimulation may activate complementary mechanisms that enhance efficacy. So for a person undergoing TMS treatments, like I mentioned, with the deep TMS, you do 1980 pulses in 1 session, or 3,000 TMS pulses with the surface TMS. They come in daily for the treatment for the first 4 to 6 weeks, which gets them to 20 to 30 treatments. And then after that, we do either a 3-week taper for 6 treatments, or 2 sessions per week for 8 weeks. So the usual duration is about 9 to 12 weeks, and we deliver a total of 36 sessions over that period. The treatment duration is 19 minutes for the deep TMS machine, 37 minutes for the surface TMS machines. Unlike ECT, there's no approved maintenance protocols for TMS. So if someone has a recurrence of their symptoms, then we wait a few months and then we do the whole course again. Then folks at Stanford came up with this accelerated intelligent neuromodulation technique, which is an MRI-guided selection of the brain target region. And here we do intermittent theta burst stimulation multiple times in the day. So like 10 treatments a day, which each lasts 10 minutes for 5 days. So this has to be done in the inpatient setting because we are doing 10 treatments a day. So that will take a long time. But they had really promising results, up to 90% initial response rates, but we don't know about the long-term benefits of this treatment. So what are the contraindications? Because we are using a strong magnet, we need to make sure there's nothing metallic or conductive metal in or near the head. So some examples include any metallic hardware like aneurysm clips or endovascular coils. There might be deep brain stimulators, bullet fragments or shrapnel, cochlear implants. And something I learned with TMS was even tattoos, facial. Some people have facial tattoos that have metallic ink in there, and that can get pulled. So we need to make sure we exclude those people as well. And people whose job is welding or welders, they just have bits of metal embedded in their faces or their heads. And again, that would be a group that we would exclude from this treatment. And also anything that could be affected by a magnetic field, like implanted electrical devices like pacemakers and intracardiac lines and medication pumps are other examples of folks we would exclude from TMS therapy. Seizures, unlike ECT, we want to avoid seizures with TMS. It's a very low risk with this treatment, but we want to avoid patients who would be likely to have seizures with TMS treatments. Because seizures is not the mechanism of action, it's not the modality by which we are treating. It's mostly the magnetic stimulation of the surface areas of the brain. And also we need to make sure that people don't have any unstable general medical disorders before we start them on TMS treatments. So like I mentioned, seizures, the risk is pretty low in the general population, but certain people are at increased risk. This may include people who already have a history of epilepsy or a family history of epilepsy. They may have had pre-existing neurological conditions like prior head injury with loss of consciousness, prior brain surgery, or congenital brain malformations. Unfortunately, a lot of psychiatric medications, especially lower the seizure threshold, meaning it makes it easier for someone to have a seizure if they're on this medication and then you do TMS on top of it. So examples include bupropion, stimulants, tricyclic antidepressants, antipsychotics, theophylline. So a lot of medications can affect your seizure threshold. If someone's going through alcohol withdrawal or benzodiazepine withdrawal or anticonvulsant medication and stop taking their medication, again, that would be an increased risk for seizure. Sleep deprivation can increase your risk for seizure. And those other experimental protocols like high frequency TMS, increased intensity, or shorter intertrain interval can also increase the risk for seizures. The other thing that can happen, other serious side effect, is mania and hypomania. So because, I mean, if you're treating depression, then if you want to elevate the mood, it can overshoot. And then instead of just getting to normal mood, they can have a manic episode or hypomanic episode. Again, this is rare because by the time people come for TMS treatments, they have tried medications as well that do a similar thing of elevating the mood. And if they've not had manic episodes with antidepressants, then it's unlikely that they'll have something like that with TMS. Some people may have vasovagal syncope as well. There are some common side effects. So you may get localized scalp pain or a headache. So the way some patients describe how it feels is they feel like a woodpecker is hitting the side of their head, pecking their head is how they describe it, or a jackhammer with the deep TMS machine. So it can be uncomfortable and it can lead to localized scalp pain. It can also cause headaches. And like I showed you, the machine is loud. It gets much louder than that, and you have to use earplugs to protect your hearing. But usually these side effects are usually mild and transient. And after a few sessions, usually people adjust pretty well to it, and they don't complain of those after a few sessions. So like I mentioned previously, in Europe, there's several other conditions where a TMS is used, like Alzheimer's, autism, bipolar disorder, chronic pain, multiple sclerosis, Parkinson's, post-stroke rehab, PTSD, negative symptoms of schizophrenia. In addition, there's some other interesting possibilities. They've even tried doing like the transcutaneous magnetic stimulation of the left stellate ganglion in people with ventricular VTach storm. And this showed that a single session reduced the recurrence to 29% versus 58% in the sham group. Other conditions that can be targeted include tinnitus, fibromyalgia, dementia, substance use disorders, and sleep disorders like insomnia or hypersomnolence, and other things. If there's other things you guys can think of and want to collaborate, we're happy to maybe do a research study. So we have those two devices which have been around for a while, but we are also getting an additional two devices. So we are getting another deep TMS setup, but this will also have the smoking addiction helmet. The green helmet will be able to do smoking addiction treatment as well. And this machine also received recently indication for late life depression as well. The other machine we are getting is a figure of 8 coil machine. So it's a surface TMS machine, but it also comes with neuro navigation. So you can actually combine this with brain MRI, and then it will allow us to do more targeted treatments of the areas of interest. And this is also the one that has received approval for chronic pain. So there's coils that you can use for chronic pain as well. Okay. So we talked about electrical stimulation, we talked about magnetic stimulation. Now let's talk about chemical stimulation of the head. So we don't offer this therapy yet, but hoping to get it started in the coming months, nasal esketamine therapy. So esketamine is an S enantiomer of ketamine. It is a non-competitive NMDA receptor antagonist. It is indicated for treatment-resistant major depressive disorder in adults. And also, I mean, it was supposed to be used in conjunction with antidepressant, but just a couple of days ago, it also received treatment as a standard, approval for as a standalone treatment as well. The mechanism of action of this drug is not clear, but it has effects on several receptors, including the opioid receptor, NMDA, and AMPA receptors. It has 48% bioavailability because it's nasally given. The Tmax is 20 to 40 minutes after the last administration. T-half is 7 to 12 hours, and it is metabolized to noresketamine by CYP2B6 and CYP3A4. So it comes in devices, and each device has 2 sprays. It's either 56 milligram dose or 84 milligram dose. So the patient administers the dose themselves in the presence of a healthcare provider, and it has to be in a certified healthcare setting. So they blow their nose, recline their head 45 degrees, breathe in and sniff in one nostril, then the other, and then they wait 5 minutes and repeat the steps again with the second device. So we do have to monitor the patient and monitor their blood pressure and vitals prior to administration, and then we check their blood pressure again 40 minutes after the last dose, and then 2 hours after administration. So they have to wait in the recovery area for at least 2 hours after they take the medication. And if after 2 hours everything looks good, if they're clinically stable, then you discharge them. So these are the phases of the treatment. So in the induction phase is weeks 1 to 4, where the first day dose is 56 milligram, and then you do subsequent doses of 56 or 84 milligram twice a week. Then you do maintenance treatments from weeks 5 to 8, 56 or 84 milligram once a week. And then you can spread it out to once every 2 weeks or keep it at once a week and make any dosage adjustments based on the response. So the clinic, as well as the pharmacy, as well as the patient, they need to be enrolled in this REMS program, or the Risk Evaluation Mitigation Strategy program. So you have to be a REMS certified healthcare setting in order to receive the medication as well as administer it to patients. And the prescriber needs to be on site to monitor the patients for at least 2 hours for resolution of sedation, dissociation, and changes in vital signs. So these are the contraindications, like aneurysmal vascular disease, AV malformation, history of intracerebral hemorrhage, or if they're hypersensitive to esketamine, ketamine, or any of the excipients in the formulation, it is not to be used during pregnancy. It comes with box warnings, especially for sedation, and there can be dissociation There's a potential for abuse or misuse because of the high that patients get. It can cause hallucinations, floating or detachment effects, and suicidal thoughts and behaviors can happen. It can also increase the blood pressure. That is why we need to monitor them for a while. It can lead to cognitive impairment, impaired ability to drive and operate machinery, ulcerative or interstitial cystitis, and it can harm the fetus. That's why it's not for use in pregnant women. And then other common side effects like dizziness, nausea, vomiting, vertigo, hyperesthesia, anxiety, and lethargy can happen. So in conclusion, neuromodulation involves the alteration of nerve activity through targeted delivery of various stimuli. It can take various forms like chemical, electrical, magnetic, and other forms. At VCU Health, we have ECT and TMS. We have a robust program going on for many years now, and we are soon hoping to get newer TMS devices, which will allow us to treat more conditions and age groups. Nasal esketamine is a promising neuromodulation therapy expected to be available in the coming months as well. I would like to thank many folks in our department. Dr. Pandurangi was the previous division chief for neuromodulation. He really was one of the first people to start our TMS in treatments in the country. Dr. Venkatachalam leads our ECT program. Dr. Burton will be involved in esketamine clinic. Dr. Smithwick provided consultation about esketamine. Dr. Tucker does evaluations for TMS. Dennis Irezo is our TMS coordinator. Dr. Sokol and Dot Parker served as the models for the for the simulation of the treatments. And I also want to thank all the neuromodulation staff. I put in the fax number for outside referrals for people who wanted to refer for ECT or TMS. But if you have a referral that you think you can send an EPIC message as well. With that, I would like to thank you all for your time and happy to answer any questions.
Hello. We'll start here in person. Oh, yep.
Oh, okay. Very interesting talk. And I was just curious, is there any data out there about either the ECT or the EMS modalities being used for like substance use disorder, particularly things like cocaine and methamphetamine addiction that doesn't really have a lot of like medication replacements?
Yeah, absolutely. So like I mentioned, nicotine addiction is, TMS is used for nicotine addiction, but they are also working on other indications, other substances as well. So hopefully in the near future, we'll have more indications along those lines.
Hi, Dr. Thakre, Gonzalo Behrman, very nice talk. The question I have is for the smoking cessation treatment. I mean, I can't get people to use like a nicotine patch.
Yeah.
How do you talk them into this?
Yeah, that's
What's your words of wisdom?
So we'll have to see how much of a response we get. But this is an additional modality, hopefully, that doesn't take too much time and maybe also have some residual effects on their mood as well. So maybe they have comorbid depression. Maybe that's how we sell it is. This will also help your
Insurance
depression.
will cover it?
Not right now. Right now, it will only cover major depressive disorder, and they have started to cover OCD as well. So it will take some years to actually get insurance coverage.
I had a question about the cognitive side effects, ECT versus TMS. TMS is less, you mentioned. How much less?
So, I mean, it's very rare that they complain of like memory problems after TMS treatments. I mean, some people might say they felt like a brain fog or something, but usually it clears up pretty quickly.
Questions here? I saw one online in the chat. Let's see. Can you even respond to that?
So great question. So yes, I mean, as far as I understand, it's the neuronal bodies that are stimulated with TMS. So the question was, does TMS stimulate the neuronal bodies, axons, dendrites, or all of them? I understand it's mostly the neuronal bodies. In terms of any magnetic stimulation targeted for peripheral nerves. So this is the device that we talked about, the last device that we don't have yet. They have this coils that can be used for peripheral nerve stimulations and chronic neuropathy and stuff like that. So yes, there are magnetic stimulation available for peripheral nerves. And it's an interesting question about the transcutaneous vagal stimulation, and that's something I'm interested in as well. I mean, theoretically, it can be done where you can possibly stimulate the vagus nerve using transcutaneous TMS as well. Another question was, are these options available at the VA also? I think they do have TMS machine. They don't do ECT treatments, but they do have TMS machines there as well. And has it been used for diabetic neuropathy therapy as well? I think the device that I talked about, the one with the peripheral nerve stimulation, that I'm sure there are studies that have targeted diabetic neuropathy as well. I think that's all that I see on here. Anyone else?
Well, thank you so much. We want to thank you.
Thank you very much.
Thanks, everyone.